The authors have no financial interest in any subject matter or material used in this film. The type of intraocular lenses and the technique of fixation in patients without posterior capsular support has been a matter of debate for long. Various options of treating aphakia are glasses, anterior chamber Kellman-McPherson lenses, scleral fixated lenses, and iris claw lenses. Iris claw lenses are PMMA IOLs with an A constant of around 117.1. These were started in 1980s and were used extensively by clipping them into the anterior chamber. However, they lost repute by being close to the endothelium. We present the retrofixation technique of iris claw lenses and we found that they have promising results. I will call it an old wine in a new bottle. We will take you through a series of videos on how to implant these iris claw lenses by retrofixation. First, let's see how to perform a classical retrofixation of iris claw lens. After making a corneal incision of around 5 mm and filling the anterior chamber with sodium hyaluronate, we make 2 ports in a horizontal meridian. We insert the lens into the anterior chamber. Then we use a forceps which has vertical prongs to hold the lens horizontally and with a good grip. One side of the lens is then placed behind the iris, and then with the other hand the 26 gauge cannula is brought from the side port in the anterior chamber. The edges of the haptic are felt and the iris tissue is tucked by a slanting downward movement of the cannula. Then we switch the hands and repeat these steps and fixate the other haptic as well. We can appreciate a beautiful dimple, and I call it dimple technique. Now, even with the firm pressure of fluid from the cannula, the IOL will not dip. We can confirm the dimple by just pressing the lens and seeing the dimple more clearly. This animation shows tucking of the iris claw lens. We first put the iris claw lens in the anterior chamber, then hold the lens with a vertical forceps, slide one haptic under the iris, and with a slant downward movement of the 26 gauge cannula, we tuck the haptic into the iris. We should be able to see a dimple to confirm the tuck. We switch hands and repeat the process on the other side. Before we go into the eye and start doing these IOLs, I would recommend that there are certain basic steps that we need to practice outside the eye. First of all, the forceps that you have should have vertical prongs to hold the lens in a good grip. This is different from the horizontal Kellman-McPherson forceps which is used for IOL holding. Then we should have an instrument like a 26 gauge cannula for tucking the iris into the haptic. The maneuver that we need to practice is a slight, slanting and dipping movement on top of the IOL. This we can do with the help of a fabric and using the lens. In India, we have special circular rings to hold the cloth on which fabric is tied and embroidery is done. These are called embroidery hoops. We can use this to hold the fabric stiff and then practice this maneuver. In this video, we have retrofixated the iris claw lens in the fabric. Now if we pull the lens after tucking, then the haptics can break, as you can see here. This can happen inside the eye as well. Now a few of our videos in the learning curve always have a good grip of the IOL by holding the lens in the entire breadth of the lens. In this particular case, after removal of a subluxated lens and doing anterior vitrectomy, I decided to put the iris claw lens. However, my movement of cannula was not horizontal and down. It was only down, and you see what is happening. The lens is actually coming over the iris. So I was struggling here and I struggled to tuck the lens in this particular patient. Now look at this patient. This was a posteriorly dislocated IOL with bag in a previously operated retinal detachment of a high myope by me. After tucking the second haptic, I could not appreciate the dimple, and the IOL was dangling in the vitreous cavity. While trying to lift it up, I saw a suprachoroidal hemorrhage just close to the macula. This was a panic situation. It made me hurry. I could hear my heart beat. I decided to be a little more bold, and in one last sweep, I managed to tuck in the loose haptic and save the day. I realized why this happened. My technician had closed the infusion cannula to prevent the iris prolapse, and this led to hypotony and suprachoroidal hemorrhage, especially because the patient was a high myope. So try and not close the infusion cannula, and please maintain the intraocular pressure at all times during the surgery. I was bubbling with energy that I could retrofixate the iris claw lens in any situation until I landed up with this particular patient. Here, after the lensectomy, I had to abandon the retrofixation just because the pupil was not constricting. Until I learned pupilloplasty to combine with iris claw lens. As you can see in this video, after tucking the iris claw lens, we did a pupilloplasty to manage the enlarged pupil. Finally, I want to emphasize the importance of a firm grip with forceps having vertical prongs, the slant dipping of the cannula to tuck the haptics, and the dimple to confirm the tuck. And this confirmation can be done by just pressing the IOL. We have had good results of using these IOLs for the past few years, and I certainly feel that this technique is worth comparing with other modalities of treatment of aphakia like scleral fixated IOLs. I hope that after watching this video, some of you will go back and surely try it out. Thank you. This is a Lall 2020 eye care presentation.